We'll be getting started in just a few moments. Hi, everyone, and welcome. I'm Liz Whitehead, Managing Editor at U.S. News and World Report. Thank you for joining today's webinar, How Community Partnerships Can Transform Children's Healthcare. Our experts today will discuss how innovative hospital-community collaborations are addressing the social determinants of health and critical healthcare challenges, making a real difference in the lives of kids and families. Today's session is the latest installment in our special Pediatric Priorities virtual event series, where we explore what children's hospital executives, pediatric providers, and key community stakeholders can do to improve the well-being of America's young people. You can learn more about all of our past programs and today's speakers at usnews.com/pediatric priorities. We are recording video of today's session and we'll be archiving the video on usnews.com. We're also simulcasting on Facebook, LinkedIn, and YouTube. Now, I'm pleased to introduce our distinguished panelists. Dr. Cynthia Cross, Division Chief of Pediatric Hospital Medicine and Medical Director of School and Mobile Health at Le Bonheur Children's Hospital and Associate Professor of Pediatrics at the University of Tennessee Health Science Center. Dr. Michelle Lopez, Associate Professor of Pediatrics, Department of Pediatrics, Division of Hospital Medicine, Baylor College of Medicine, and Texas Children's Hospital. Dr. Monica Mitchell, Senior Director for Community Relations and Professor of Pediatrics in the Division of Behavioral Medicine and Clinical Psychology at Cincinnati Children's Hospital. And Gretchen Todd, Executive Director of Diversity, Inclusion, and Community Affairs at St. Louis Children's Hospital. One final note, if you have questions during our panel discussion, we invite you to type them into the Q&A feature in Zoom on your screen. I will try to give voice to some of those as time allows. Now, let's dive into our discussion with our panel. I'd like to ask each of you to start off by offering us a quick snapshot of your roles in the communities you serve. Monica, can you begin?
Yes. Thank you so much for the invitation. So I'm Monica Mitchell, and I'm a pediatric psychologist, and I'm also the Senior Director of Community Relations. So a big part of my job is to connect the work that we do inside the hospital with the work that we do in the community. So just a little bit about our community in our hospital. So we have 1.5 million patient encounters each year, so that's quite a lot. We serve patients from all 50 states and patients from around the world, so dozens of countries. We also serve our patient communities. So we serve rural, suburban, and urban communities, and that brings me to my role, which is I'm in charge of community outreach, community engagement, community investment, and community benefit.
Thank you. Michelle?
Yes, hi, thank you. So I'm Michelle Lopez. I'm originally from the Rio Grande Valley in South Texas, but I've been in Houston for over 20 years. I'm at Baylor College of Medicine and Texas Children's Hospital. We're a quaternary care freestanding children's hospital, so we are a referral center and have a large and ever-expanding community that we're serving here. It's a racially and ethnically diverse community, a great place to be engaged in health equity work, which is a big part of what I do. I'm also part of the Center for Medical Ethics and Health Policy here at Baylor College of Medicine, so really looking at how upstream population health, health policies can influence and improve health equity. And in the hospital setting, a lot of my work is looking at screening for social needs and connecting with community partners.
Thank you. Cynthia?
Good morning, everybody, or good afternoon, depending upon where you are. We're really excited to be here and want to thank Elizabeth and U.S. News and World Reports for recommending me for this panel, also for Sarah Burnett from my home institution for referring me as well. I didn't want to forget to say thank you. That's why I started with that. I'm a native Memphian. I grew up here. Memphis is the second largest city in the state of Tennessee and roughly the 28th largest city in the U.S. Our medical center is a freestanding children's hospital with all specialties represented. I am a pediatric hospitalist, but probably about a year after I came back, I was invited to take a ride to the country per se, to see where our mobile medical unit services patients. and asked if I wanted to be the medical director and how could I say no. So our mobile unit serves rural West Tennessee. Tennessee borders Mississippi, Arkansas, and Missouri, so we have a good number of rural patients, even though our home base is at 276-bed Children's Hospital. We also have several programs that are nationally and internationally known, namely our neurosciences and cardiovascular services. So we also have kids who come to us from all over. About a third of the kids in Shelby County, which is the county seat for Memphis, live in poverty or live in or at the poverty line. And those kids come here, but the majority of those kids don't come to the hospital, right? So I have been privileged with the ability to bridge the gap between inpatient and outpatient medicine. Really excited about being on this panel, and I look forward to hearing what everybody else is doing. Thanks.
Thank you, Cynthia. Greta?
Yes, hi, thanks, Liz. I'm Greta Todd. I'm the Executive Director of Diversity, Inclusion, and Community Affairs at St. Louis Children's Hospital. St. Louis Children's is a 400-bed inpatient hospital that is part of the BJC healthcare system. And we also are partnered, our academic partner is Washington University School of Medicine. I have been at St. Louis Children's for about 17 years, although I started my career at another children's hospital in Washington, D.C. for a few years. So I've been in the children's hospital world for some time, and I think all of my colleagues can attest to this. Once you kind of drink the Kool-Aid, it's hard to leave the children's hospital world. The community that we serve in St. Louis, I mean, we're geographically kind of right in the middle of the country, obviously. And we have in the city of St. Louis about 300,000 people. And of those, that population, we have about 30% of the children live in poverty here. The other dynamic we have going on in St. Louis is our racial diversity. Actually, we are predominantly African-American and white, almost 50-50 in the city of St. Louis. So, which makes us different from a lot of other metropolitan areas that have a lot of different languages and races and things to consider. Our dynamic here is pretty much about Black and white. My job and my role at St. Louis Children's Hospital is the community affairs part is I direct all of our community outreach programming. So I have a staff of about 80 or so people, and we have, by the end of next year, we will have 6 mobile units. We have school nurses, mental health providers in the schools, virtual care, home visitation, car seat stations, weight management, teen outreach, all kinds of interventions. I'm sure I forgot some of the groups. I'm sorry to my team if I've forgotten you. And so we reach well over 30,000 children a year. And then the diversity and inclusion part is helping our organization through their equity journey, and how that relates to our work in the community is the common link is the disparities. We're looking to eliminate disparities as our #1 goal. So enjoying being part of this panel, and thank you for including me.
Well, in talking to all of you and in listening to hospital leaders across the country, it seems that while there are many, many major problems affecting community health right now, the mental health crisis seems to be at the top of the list for almost everyone. And I'd like to actually give you all a chance to talk on that issue and then some of the programs you're doing. And I'm wondering, Monica, if you can start us off and first sort of characterize how serious you think this crisis is, and then talk a bit about what Cincinnati Children's is doing, what kind of multi-pronged approach it's taking to address it. And then I'm going to bring you all in.
Yeah, so as a pediatric psychologist, the past 25 years, I mean, this is something I've seen up close and personal. But I just want to kind of put this in perspective. So right now, while we're on this call, we know that 1 in 5 children and adolescents are suffering from mental health illness. If we go younger, so talking about 2 to 8-year-olds, that's 1 in 6, which is shocking. If we go older, adolescents, we're talking about 1 in 3 or 1 in 4. I mean, it's really startling information. Some of the things that we're doing at Cincinnati Children's, we are taking a multi-pronged approach. So among pediatric institutions, hospitals, Cincinnati Children's has the largest number of beds dedicated to mental health treatment. So at our College Hill facility, we're doubling down, making an additional $100 million investment in that campus to be able to put more beds in that campus. So we have 130 dedicated mental health beds across our campuses, for example. We're also making significant investments in research. Want to mention one investment where we just made a $10 million investment in that research, and it's artificial intelligence research, because we know we have to think about predicting mental illness, not just treating it. So this is Dr. John Peshtian's work, where he uses genetic, environmental, and social factors to be able to come up with predictors of, how can we even think about, and he's I don't know if you've read his work, but he has used suicide notes, for example, thousands and thousands of them, to look at keywords in suicide notes to be able to predict suicide risks. But he's going beyond that to look at other kind of mental health conditions. So
Can I ask you a quick question on that? Is
Yeah,
that
sure,
something that
absolutely.
could be used by any pediatricians or therapists, that kind of AI and analysis?
Yeah. I mean, the findings they've already been disseminated to to a degree, but he's looking at he's looking at mental health risks more broadly. But it is very innovative research, and that's something that we know we're going to have to do, is really think about innovation when it comes to mental health. We're going to have to go upstream and think about not only prevention but also prediction of mental health risks. And then that brings me to another point, which is, that early childhood piece. We also have researchers who are looking at early childhood factors that we can think about in terms of ensuring that kids who've experienced early childhood trauma have the best possible outcomes. And then the last thing I'll mention is the programmatic piece of things. So we are partnering with community partners. We partner with a group called Mind Peace that has mental health partners in all of our public health schools, partnering with Job and Family Services and other partners, so that we are doing both prevention and intervention programs in places where we know that kids need those services.
Thank you. Michelle, can you tell us what you're seeing at Texas Children's?
Yes, yeah. So my primary practice is in the hospital setting, and I absolutely agree with Monica in terms of the crisis we're seeing. It's not uncommon when I'm on service taking care of patients. In the past, I'd have maybe one on my team of 15 patients, one patient that maybe was there with mental health issues, a suicide attempt, which already was one too many. We want to get, like Monica saying, back to the prevention and prediction piece of it. But now it's so much worse. It's not uncommon for me to have 6 or 7 patients who are admitted with suicide attempts, behavioral health issues, aggression. And so we've really had to step up our interventions in the hospital. We have created a behavioral health team where we have behavioral health technicians that are trained to work with these patients, as well as behavioral health advanced practice providers. And so the benefit of that is these team members can really get to know the patients well, develop rapport, focus a lot more on the non-pharmacologic interventions to help the patients while they're in the hospital, while we work on identifying ultimate placement for them, whether that's intensive outpatient or inpatient psychiatric care. And so our psychiatry and psychology departments help us a lot with the care of the patients in the hospital. And then we have a really strong community partner that's a mobile crisis assessment team that partners with hospitals like ours and ERs, and will come in. They're licensed counselors. They'll do an assessment with our patients in the hospital once they're medically clear, and help us and help the families with resources for the next steps, including transfer to inpatient psychiatric facilities.
Thank you. Cynthia, can you talk about Le Bonheur, and also, do you have a sense of how stretched your resources are? If this is such a big crisis right now, can you also give that perspective?
Absolutely. Yeah, we were in a crisis with behavioral health long before COVID came, and then COVID came and it just magnified the problem. You can't really separate mental health for children from the health of the families. And once COVID hit, families had increased stressors, right? the fear of losing a home, or they lost a job, or they needed childcare for kids who were no longer in school for 8 to 10 hours a day. And many of our programs are actually aimed at building resilience in families, helping before we see kids who are at the breaking point where they're committing suicide. We saw our suicide rate for admissions double. And so that is just the tip of the iceberg, right? When you think about the fact that most kids never end up in a hospital or in a mental health facility. So they're still out there struggling with the same kind of stressors. We have done webinars to talk with families about how to talk with their children. We have partnered with our school systems. Our school system is one of the largest in the nation, and they have started some community mental health centers, and those of us here have actually gone out to see them. We have a great partner in the Urban Child Institute who not only provides funding for programs like one called Lena, which is a partnership with our visiting nurses. And these providers go out and kind of walk hand in hand with these families for kids under 8 years of age, sponsoring childcare, sponsoring early intervention programs. We have tried to strengthen what's out there and then come up with new ways of taking care of kids. We've used telemedicine for some of the inpatients. We've also reached out to Youth Villages, which does our mobile crisis assessment, to hone up our processes there to see if we can more efficiently take care of kids, because some of these kids come in and they're here for weeks because we can't find an inpatient facility for them. So those are some of the things that we have done.
Greta, can you pick up on some of these points and then talk about how you're approaching mental health challenges?
Yeah. Sure. I think Dr. Cross was spot on. COVID just exacerbated what was already an existing problem. We had at St. Louis Children's Hospital, we had opened a new inpatient behavioral health unit a few years ago. But then when COVID came, the emergency department was just slammed with just so many behavioral health patients. One of the things that we are trying to do at St. Louis Children's is work a little bit more upstream inside the schools. And so we started back in 2017 with some partnerships with some school districts and charter schools where we embed mental health providers inside the schools. So they go there every day. That's where they work, and they take build a caseload right from the school. And we are in a probably, I don't know the last number, maybe about a dozen schools in an embedded way. But then we also, especially with COVID, COVID helped to accelerate the use of telemedicine. And so we had also started a virtual care pilot in one school district in the right as COVID hit. And we were able to secure some donor funding to expand that program. We're so fortunate at St. Louis Children's Hospital. The St. Louis Children's Hospital Foundation has incredibly generous donors who respond to our call for help. And so they did so in this case. And we secured some funding with a goal of expanding virtual care into 55 schools in 5 years. And we are on track to do that, to provide, that access to that kind of care for those kids. So that's just a couple of ways that we're trying to expand our reach. The problem is finding the providers. So we can place telemedicine equipment in every school, but if you don't have the provider on the other end to be able to respond, that's where the problem is. Not only finding the providers, but finding providers who are culturally competent and who look like the children that they're serving. That has been the biggest challenge that we faced with mental health services.
Is there a way that you all are trying to find ways to deputize maybe sensible adults, the pediatricians, the school guidance counselors? Is there any way that they can help a little bit with some of these problems?
I think you're right. The school guidance counselors, they're stretched pretty thin as well. The AAP has come out with additional training for pediatricians on behavioral health, using the workforce that we have already. I talked to one of our social workers, and she said one of the problems with becoming licensed to provide counseling is just financial. So there have been efforts to provide, say, a stipend for a provider to go and get that additional training. we are in the Bible Belt, so there are also churches that have counselors, and we have a community health network that is a group of churches. There are hundreds of churches involved with that. But I would have to agree with Greta. We need more providers. And I don't know how you get more providers to stay in behavioral health that's not private practice, which is not reimbursed as well, right? Because that's a problem as well. Even if you found a provider, that family wouldn't be able to afford them. Our mobile health unit does a good bit of case management and trying to plug families in with community health centers that are in the rural areas. But it is difficult, and it's not getting better, unfortunately.
So the pandemic has obviously exacerbated all this, and Monica, just shifting back to you for a second. You have had to reach out into the community because not only has mental health been exacerbated, but you've also had children's vaccine schedules be interrupted. I know that Cincinnati Children's has done a lot of programs both to encourage COVID vaccines and getting kids back on their schedules. Can you talk about how you've gone into the community and addressed these problems and what you've found that works?
Yeah, one thing we're really proud of actually is that we've been successful in vaccinating over 40,000 children over this past couple of years during COVID. And part of the way we've been successful is creating some new ways to provide clinical services. So we've had to be nimble and we've had to be flexible. And I would say a couple of things that we've learned is that we've had to meet people where they are. So we've gone out to parks, we've gone out to churches, we've gone out to schools. Honestly, we've set up tents on corners. And the second thing is that we've had to, we've realized that communication has changed significantly. So some things we would only print in English, now we print it in multiple languages. We take our translators with us. Yeah, we've used our mobile van. I think we put more miles on that thing than we have ever since we've owned it. We've taken it on the road. And we've even gotten more creative about using it in lots of different ways. But, and then I would say the last thing that we've done that has actually been pretty fun is that we've learned how to be more welcoming, how to be more hospitable. So sometimes we've turned into superheroes. Sometimes we think, oh, this is during the lunchtime. Maybe we should provide some boxed lunches and some things like that. And even just putting that on a flyer, we do transportation vouchers. We have some people who want to donate these things. And that has made all the difference. And I would say one of our really coolest stories was because we go in low vaccine communities, which is directly related to our health equity mission. And one of the coolest things is when we did one of our first clinics in this community where no one had been able to penetrate before, and we said we got to pull out all the stops in this community. And we did about 10 different things, seriously. We did the lunch, we did the superheroes, we called this one a holiday clinic and gave out little Christmas and holiday gifts. And an hour before it opened, we already had a line, and we did over 400 vaccinations that day in a 3-hour period.
Oh, that's amazing. We're going to get into a lot of more of the programs that you all are doing, but I'm wondering, Michelle, if you can talk a little bit, because Houston is such an international city. You've got a very large Hispanic population too. Can you pick up on what Monica was talking about, the need to have multilingual outreach, culturally sensitive outreach, and how you see that's evolved over the last few years through Texas Children's?
Yes, yeah, I absolutely agree. It's such an important consideration because really we jeopardize the non-English speaking or limited English proficiency population, jeopardize worsening health disparities in that population when we neglect to provide, materials in their preferred language. And so for us, one study, in addition to having a large Spanish speaking population, a lot of our Spanish speakers are also immigrants. So one study that my colleague did, Dr. Marina Michelli, is she had a lot of qualitative interviews with our families in Spanish and really explored their perspectives and their experiences. And there were unique needs that were coming up from them that we weren't aware of, that was really important in informing our social needs screening program. So for example, just the fear was the biggest thing. The fear of, even in our documented immigrants, still fear of deportation, fear of being separated from their children and their families. Of course, the language barrier, unfortunately, discrimination, complexity of some of our applications for public resource programs. And so from that, we really learned the importance of making sure that we were, one, transmitting information and the languages needed by our population, but also listening and giving our marginalized population a voice. And I think we have so much power to do that as children's hospitals because we're largely recognized as safety nets for the medical care for some of our lower resource populations. But I think we're also a safety net for social needs and for helping identify some of the other risks that our families have. And so through that work, we've been able to partner with community organizations that specialize in helping families that are from immigrant backgrounds that have some of these fears, providing options that they feel more comfortable with, providing counseling to just kind of share with them what their rights are. So that's been really important for us as we've moved forward. Thank you.
So I'd like to deepen our discussion into tackling the social determinants of health. Cynthia, a big problem for many families is securing safe housing that provides a healthy living environment. And can you talk about how Le Bonheur is screening for this problem, and how do you identify a housing need, and what are some of the innovative sort of tools that you put into place to more efficiently address these issues? And then, if you don't mind explaining how this cascades on the health of the people in the family in these homes if they're not safe environments.
Absolutely. So I'll start with a story that about a patient that I encountered shortly after I came back to Le Bonheur in 2008. Is a young kid of Hispanic background who was frequently in the hospital with respiratory infections. And I think some people thought it was for respite care, but her family never left her. They were always with her, always great with her. She was well cared for, but she kept getting sick, and it was always respiratory infections. And I went in with our translator and our pulmonologist, and we sat down and we said, first, let us explain that we love taking care of you guys every time you come in, but we know it's disruptive for you to be in the hospital every 4 to 6 weeks. So tell us what's going on at home, or what do you think is making her sick? And make a long story short, they had substandard housing. There was an air conditioner in the room where this kiddo slept that leaked. So there was mold in the room. And they told us they had to keep the rats off the bed. Now, those of us listening to this discussion thought, well, this is a slum landlord, right? But this family thought the man was wonderful. So what we did was we used that to our advantage. We wrote him a letter, told him how much this family admired him, but that their daughter was getting sick from the housing, and he fixed the house. So sometimes what we're seeing as an illness is actually a reflection of the social determinants of health. Many families can't afford better housing, and many times no one holds these landlords accountable for maintaining the property. So one of our partners at the Urban Child Institute is very interested in advocacy for adequate housing and legislation, and they've really done a good bit of work there. So they have helped us. We also have a medical legal partnership, which is a co-op between our medical providers. One of our hospitalists is actually their medical director, and they have partnered with the University of Memphis School of Law and the local, why am I blocking on our federally funded legal services agency as well, and they have tackled some of the housing problems for families with substandard housing, or even some of the evictions that have come up. The Urban Child Institute also knew about funding that came available during the COVID pandemic, and unfortunately some of that money was sent back just because people didn't know about it. So there's also a need to coordinate what is available for families. And then Michelle touched on literacy. Some people don't read very well and they have trouble filling out the applications. Our social workers here at the hospital will help families. We started screening for the social determinants of health formally, because if you don't ask, you won't know, right? Sometimes people are just hungry. I had a mom who looked distraught every time I came in the room, and she finally broke down and told me she was just hungry and no one could bring her food. Well, we now have food pantries on every floor, and people don't have to ask for food. We ask them, are you okay? What do you need? Just those kinds of things, really looking for more than what meets the eye, and not blaming the families, but asking them what's going on with them that has landed them in the hospital. And I say that, but we also have to remember that only a fraction of the kids ever end up in a children's hospital, right? And most of the kids are in our community, and social determinants of health are so important to their well-being. If we want these kids to succeed, we have to address the social determinants of health. It's our responsibility, right?
Yeah, I'm going to turn to Greta and Monica next, but I have one follow-up. What happened to the little girl after the landlord fixed the house? What was the impact on her?
Yeah, so that's the best part of this. She was rarely in the hospital. In fact, there was a point where I thought maybe she had passed away. And then she showed back up one day. I mean, she would go years without coming into the hospital. She's an adult now. And I thought the other day I might look up her name just to see if she's still in the system. But the turnaround was amazing. And they were so happy and so thankful that we thought enough to sit down with them and ask, hey, what's going on with you? Because, you know, many times we do make assumptions, right?
Yeah, that's wonderful and heartening. Greta, can you pick up on some of these issues? And I know that a big concern of yours is maternal and infant health, and what's been going on, again, because of the pandemic, the impact on mothers. Can you talk about what you're seeing in the rates of premature births and low birth weights, and how you're trying to address them?
Sure. Yeah, there's a direct connection to what Dr. Cross was talking about, housing. Housing is one of the biggest issues that a lot of our families face. We do have a strong focus at St. Louis Children's and at BJC Healthcare around reducing infant mortality and specifically targeting the disparity. A Black baby is 3 times more likely to die before their first birthday than a white baby. So that's a huge disparity that we've been trying to work on here in St. Louis for some time. We do have a program here called Raising St. Louis, and at its core, it's a home visitation program. We partner with a local organization called Nurses for Newborns, and nurses will visit the home when mom is pregnant up to the baby 2 or 3 months old. And then they will do a warm handoff to a parent educator who uses the national curriculum from Parents as Teachers. So we are a Blue Ribbon Parents as Teachers affiliate at St. Louis Children's Hospital. And so our parent educators will go into the home and help families. But we were noticing that a lot of our families were really unstable. They couldn't focus on the lessons of Parents as Teachers because they were worried about their eviction. They were worried about legal issues. They were worried about food. They were worried about all of those social determinants that impact health dramatically, impact infant mortality dramatically. And so that's when we started our community health worker service line. And so we can now refer families into a community health worker who will help them address those social determinants and get them more stable. And when they're ready, they can move back to a parent educator at that time. We also offer mental health services through this program. We have a social worker who runs mental health groups with moms. We also recently signed a contract with a local organization. It is Black male therapists who are we're specifically targeting the fathers and the father figures in these children's lives. They also impact health. In fact, our latest class we started with, we have a class for fathers called 24/7, an evidence-based curriculum. And we started this class inside the Justice Center. So for fathers and father figures who are in the Justice Center, many of them not convicted of anything, but are there waiting for their trial. they can go through this class. And our goal is to eventually have this class work towards their points for early release or their parole, that kind of thing. And we also have a number of community hub locations, which are local inside the community at trusted community locations where people can access all kinds of services, financial classes, yoga classes, pancakes and pajama parties at the holiday time. All of those things impact a family's health. And we know that the whole community has to be healthy in order for a child to be healthy. So we're working towards this, eliminating this disparity. And the rates were getting better and better, rates of prematurity and low birth weight. We were seeing them come down and down and down. And then COVID hit and it shot back up again. So the value, even though we continued doing our home visits via Zoom and we continued delivering diapers and some other things throughout the pandemic, that home visitation, it's been proven over and over again that home visitation is one of the most effective ways to impact prematurity and low birth weight and infant mortality. And we saw that happen here. The pandemic had a huge impact. So we are starting over and working towards bringing those rates back down again. So.
Yeah, thank you. And one of the sort of sub themes is coming up is how critical it is for community health experts to really understand what's going on in people's lives and what their concerns are. Monica, I'd like to ask you to tell the story of the baby milk shortage and what you did as an example of how important it is to circulate in the community and really understand all the cross currents and issues going on. Can you explain what happened with the shortage, what you saw, and how you responded?
Yeah, sure. Happy to tell that story. So one thing I know about working in community relations is oftentimes we'll hear about pressing issues from the community before we even hear about it from the news. So we started getting calls about the infant formula shortage from mothers in the community who were frantic that they could not find infant formula on the shelves. And they were asking, hey, is there any resource you know about, or is this something, Cincinnati Children's? And while we were hearing about this problem, we were also hearing about mothers who were telling us what they were doing about it, which is they were either watering down milk, they were giving their baby, juice or other things that were not good for their babies. And it was very scary what we were hearing. We were also hearing about mothers who were spending way too much money on formula because there was essentially a black market forming where people who had access to formula and people who didn't were exchanging formula. So mothers were spending their rent money to buy formula, which was creating a secondary problem as well. So this really created an opportunity for Cincinnati Children's to think about how we could work with partners, food banks or churches to think about addressing the issue. So we work with our supply chain office to provide, because we did the inventory and we saw that we had a lot of formula on hand to really create a inventory system where mothers, could provide proof of that they actually had a baby and things like that to address the issue. But we learned a lot in the process. One, we learned how the community is really a good source of information for even more so than sometimes the news about, what the problem is. But we also just learned how, how we could also not only provide the formula, but how we could provide nutrition education around breastfeeding, around feeding babies the right thing. And then a very interesting thing that we also learned is that mothers relied heavily on name brand formula, Isomil, Similac, and they didn't understand that those generic formulas were equally as nutritious if they just knew which generic formulas to buy.
So how did you communicate that information to them? How did you get that information to the community?
Yeah, so I mean, the networks, the community networks are in place, you know, whether it's churches, the WIC offices, the food banks, and we created, and we already have these networks in place to communicate things. So we send out a monthly newsletter to the community. That was already in place, and we also, you know, used some social media sites that the community was well versed on. But it works very well, and we're actually still doing some of that now.
Now, am I remembering correctly, just one more question, that there was actually a black market
Yes.
for baby formula that created this,
Yeah.
probably the
So
sense
what
of
was
panic?
happening was there was a Facebook site that was telling mothers, like, hey, go out to the Target out in, you know, 40 miles away and you can find the formula. But what was happening is that people who had transportation were going out and getting the formula, bringing it back into the inner city and selling it to moms who didn't have transportation for 4 times the value of the formula. And moms were spending their rent money or their, you know, whatever income that they had on it. And then what was happening is come the first of the month, they didn't have their rent money. So it was creating the secondary problem of income redistribution, that now moms don't have formula and now they're faced with this housing issue. So we were hearing about it both ways.
And all of this, because you all are in the community and constantly talking to them, you
Right.
get this information, which impacts your ability to tailor your response in a really, really effective way.
Right.
So Michelle, you've talked about that you're able to do a lot in the hospital to do social needs screening. Can you talk about some of the things that you've done, perhaps tied to food insecurity, screening for postpartum depression, what you're able to do at the hospital bedside, including the families, not just the patients?
Yes, yeah, I think that's been a really important direction of our work. And you know, Cynthia talked about that mom that's in the hospital and doesn't have enough to eat, and kind of what you see on the provider side from that. We've done a lot of work on food insecurity, both household food insecurity, the food insecurity that families are experiencing in their home, but then also on caregiver inpatient food insecurity, which is less commonly described, but something we see in the hospital where caregivers don't have enough to eat while they're in the hospital with their children. And sometimes children are there for a couple of days. It might be something acute. Sometimes they're there for weeks, especially, you know, some of our medically complex patients. So we've done a lot of work describing that with my colleague, Dr. Claire Bocchini, and one of our fellows had led our original project, Dr. Alice Lee. And it was just startling to see the numbers. So the first project where we were really just trying to understand the problem, we saw that 38% of the families we screened had household food insecurity and 43% had this caregiver inpatient food insecurity. And thinking about how that might impact the parent and the child, thinking, you know, parents described that they would sleep to deal with the hunger pain, that they weren't able to be engaged. They felt like the team thought that they didn't care, but really they just didn't have any strength, and they were struggling. Sometimes they would eat just what was left over on their child's tray before it was picked up. So we were able to get funding, philanthropic funding. Greta had talked about this, and this is so important in our work. We got support from a community business who funded our next study, where we screened 1,000 patients for food insecurity. And this was during the pandemic from 2021 to 2022, and saw the numbers had even gone higher, sadly. So 48% screened positive for household food insecurity and 46% for inpatient. So we saw that huge increase in household food insecurity, which is something we, you know, are unfortunately seeing in the community. And so one of the big things about this work that I'm really grateful for is we were able to partner with the Houston Food Bank for the intervention. So the funding allowed us to provide meals for the families in the hospital, but then thinking about how do we address the ongoing household food insecurity needs. The Houston Food Bank was our partner for this. So some of our past social needs screening work, we had passive referrals where we would give the family a phone number to call and ask them to follow up with the resource. But parents in the hospital have so much going on with the sick child, missing work, thinking about their other kids at home, and we found they weren't able to connect with the resources. So with this program, families consented to the Houston Food Bank calling them to follow up. And we saw a huge increase in the amount of families that were connecting. And at that point, they were screened for whether they qualified for SNAP benefits. They had assistance applying for SNAP, assistance finding food pantries in their area. And then another really neat thing that our Houston Food Bank does is they also screen for other social needs, recognizing that if they can help families get more help with rent and utilities, then that's more money to support them and their other needs, medicines or supplementing food. So that partnership has been really amazing way for us to be able to support families more. And I think it's very clear to see the bi-directional relationship of it, where we have been, according to the Houston Food Bank, their most successful referral stream from a health provider in terms of identifying families that have needs. And then on our side, not adding to the workload of our social workers, being able to have the Houston Food Bank help the families has been incredibly important. And so now we're looking at future innovations of what we can do with that, having the Houston Food Bank navigator on site to help with applications in the hospital. And I think that it's limitless what we can do. And so I'm really grateful that we've been able to have that partnership.
Thank you. Cynthia and everybody on the panel is basically talking about trying to move more into prevention and getting out of rescue mode. Can you talk a little bit about how important it is and how perhaps you're trying to develop more wraparound services for kids to stop problems before they blossom, which ends up being better for everybody?
Yeah, it's better for everybody, and it's a lot less expensive, right, to prevent a disorder than to have to maybe bear the burden of that lifelong. And it's not just financial burden, but also emotional burden for the family. I think that once you identify one need, if you look, you will find others. So the food insecurity, and then you ask a family, what happened last time we noticed that you didn't show for your follow-up appointment or you didn't get the medication? Then you realize they need help with getting the medication, or transportation is a problem. It is really important for us to connect with our communities, and we don't have to reinvent the wheel. There are already plenty of agencies in the community that know what the problems are, but everybody's siloed, right? And so if we as the Children's Hospital don't reach out, we don't know what the needs are. And we've really done a good bit of work in reaching out to our communities. If they're having events, we show up. If there is a need, we try to help. When COVID hit, we organized webinars and we talked to families. We organized webinars with the school system. For social determinants of health, the evidence is there, right? We can no longer ignore it. It's much bigger than any disease burden that we have. And we as hospitals have the resources, and most of us are benevolent, right? We want to help. Our asthma program looked at social determinants of health and how they affected kids in Memphis with high-risk asthma, and our asthma admissions dropped dramatically. Our partners, the Urban Child Institute, has done a great job of helping us fund wraparound programs for families, particularly for kids who are under the age of 8 years of age, violence prevention, training for families, visiting nurses, seeing these kids at home. We've already talked about makes a big difference for them. Wraparound services are a lot cheaper. We all know that. Our problem is, how do we convince those who make the decisions on budget that that's the way to go? And I think that's where advocacy comes in, right? And we all have to advocate for our kids. We have to tell their stories. We have to tell our family stories, because maybe they don't have the connections to tell those stories. The first time I went to Capitol Hill, I was so surprised at how interested they were in what we had to say. We work with the Children's Health Fund, and they spent a day preparing us to talk with legislators. And we got there, and I'm thinking they probably don't want to hear what I have to say. And I was so surprised. I was even more surprised when I saw some of that come to fruition in legislation. So we can make a big difference. We're organized, we have the resources, and then our communities want us to help them, right? and our kids deserve this.
Thank you. Greta, one of the issues is to identify pockets of kids who are overlooked in the community. And Michelle touched on the immigrant community. I know you serve a large refugee community. Can you talk about what you've tried to do and perhaps how historically overlooked they've been in terms of their healthcare needs and why it's important to address them and how you're doing that now?
Sure. Yeah, that is one of our it's sort of one of our philosophies, is to go where the gaps are and to go where it's hard. And serving the refugee population can be really hard. I don't know that many people will think of St. Louis as being sort of a place where refugees are, but we actually do have a pretty robust pipeline of refugees that come into the St. Louis community, as we are a resettlement site for the Immigration and Naturalization Service, and specifically for medically fragile refugee families. And so we partner with the resettlement agency here in St. Louis called the International Institute. And one of the things that we do for refugee children is we provide their initial immunizations. And it's something simple, right? But refugee families, the parents cannot get their green card, which would allow them to get a job, until their children are enrolled in school. And schools will not enroll children until they have proof of their immunizations. And so usually twice a month, we'll go to the International Institute and we will provide immunizations for refugee children. The reason this is hard is because many, not all, but many refugee families have never been exposed to Western medicine before. And so just to get a consent form signed to make sure those families understand what an immunization is and what it's going to do and why it's important, sometimes it can take 30 or 40 minutes to consent a single family. And so that's really hard. And that's something that you don't get reimbursed for, right? If you're trying to bill. And so we take the time with interpretive services to go through that with those families and get that consent. And, another service we provide for them are dental services. We've had families in the past who, again, never exposed to Western dentistry. They thought we were going to take the tooth out, fix it, and put the tooth back in. So trying to explain exactly how, Western medicine works is a big part of the challenge, right? But it's so impactful. And these families, they come to us. Many of them have lived years, if not their whole lives, in refugee camps, and they have nothing. They have nothing, but they're so inspirational to us. And I'll tell you a story about one time we heard from a teacher at the New American School here in St. Louis, and she told us about some children arrived in the school. They had just been immunized by our Healthy Kids Express team, and they had, several Band-Aids on each arm because these kids have to get 4, 5, 6 immunizations, right? And they came into the school and they were crying because their arms hurt. And the other children came over to comfort them. They were the children who had gotten their immunizations 2 weeks prior. And they came to comfort them and they said, no, don't cry, don't cry. These Band-Aids mean you're an American now. And then they told them, take those Band-Aids home, put them under your pillow, and they'll help you dream the American dream. So these kids can get inspiration out of a Band-Aid, right? And they're hugely inspirational to me and to my team. It's been one of the greatest privileges of my career to serve them.
Wow. Thank you.
You make me tell that story, Liz. I got all choked up.
Yes,
That's terrific.
Wow. Thank you for sharing that. It's amazing. Michelle, I wanted to turn to you because Texas Children's has been working quite closely with Medicaid managed care organizations to try to amplify the efforts in community health, which is also critical in reaching as many people as possible because you have to mobilize more resources. Can you talk about what you've been doing and how that's helped?
Yes. So a little bit of background on this: when we think about the kids that are hospitalized, like Cynthia's talked about, not all of the children are in the hospital, but we do see very high-risk children coming into the hospital. And looking at national numbers in a study we did recently through the Children's Hospital Association, we looked at child opportunity index in the neighborhood. So the factors like education, healthcare access, and socioeconomic factors. And we found children from these lower COI neighborhoods are more likely to be hospitalized, and the majority of them have public payers, Medicaid, 80%. So when we think about priority alignment, it makes a lot of sense for us to be working with CMS, with Medicaid services. And we did a pilot study with our Texas Children's Health Plan, which is a Medicaid managed care organization here, with their community health workers. And so we engaged in training the community health workers in screening techniques, being sensitive to how sensitive these topics are for families to talk about, understanding the family's perspectives and providing empathy as we do the screening. And through that, in a matter of about 5 months, the community health workers screened 3,000 health plan members. We identified a third of them had food insecurity, which was much higher than had been reported previously. And then again, through this partnership with Houston Food Bank, we're able to make direct links to the food bank. And I saw some follow-up data recently where 85% of those families were enrolling in SNAP, and again, connecting with the food pantries. And so, so I think it makes a lot of sense to be focusing on Medicaid managed care organizations. Nationally, there's something, I think it's close to 40 million children have Medicaid. So when we think about reaching children, this is a great place to do it, to be partnering with Medicaid managed care organizations.
We just have a couple minutes left, but Cynthia, I wonder if you could just talk for a minute about how important it is to find the right partners. And perhaps you can talk about what you're doing with the Urban Child Institute and how that has helped some of your initiatives.
So when you're looking for partners, you don't just need money, right? Urban Child Institute has provided us a good bit of funding, millions of dollars. However, they're also great at other things too, connecting us to other providers in the community, other folks who are doing philanthropic work. They're also great at teaching about advocacy. So looking for opportunities to partner with folks expands what you can do. It also stretches your dollars, if you will. They have sponsored a number of innovative programs. They sponsored Memphis Child, which is our medical legal partnership. They've sponsored visiting nurses. They've sponsored nurses in our public school systems. They have sponsored wraparound care in certain neighborhoods in the city that are lower resourced communities. They have been just terrific partners. We've had other partners as well. FedEx is here, so they've helped a good bit. The Memphis Grizzlies, but I think sometimes we think of collaborations as who can give us money, but that's not always what you need, right? Sometimes you just need the expertise or someone to give you an inroad. We've also had great partners with the Children's Health Fund. I don't know if many folks are familiar with them or not, but interestingly, Paul Simon, the musician, and Erwin Redliner, a pediatrician, somehow met and talked about a homeless woman that had approached Paul about how difficult it was to get healthcare for her kids. And out of that grew a national organization that takes the care where the kids are through mobile units, and they have several fixed sites that are FQHCs as well. They collect data from all over the country on social determinants of health. And so that information is readily available. And then they also have the ability to pool all the interventions that these mobile projects have come up with, because not everybody can think of everything, right? But you have the access to this expertise. It's amazing. The University of Tennessee is here, and we partner with them. We have colleagues there. The University of Memphis Law School, and we're also looking at working with their psychology department. We even partnered with one of the engineering departments when COVID came to help us with some of our equipment. I just think being connected to the community pays off in so many big ways. The other cool thing about being in the community is you're a role model. So the kids out there get to see someone who maybe looks like them. I started off as a nurse because my next door neighbor was a nurse, and then ended up going to medical school years later. So just being there, going where the kids are, just makes such a difference. I've even thought maybe we should start a beauty parlor intervention and start going to the beauty parlors and talking to families. But yeah, we have great partners and we could not do it without them. This is a very resilient community, even though we have our issues, and there are folks willing to help. You just have to connect with them, right? You tell them what you need and they will try to make it happen.
Thank you. So in our last minute or two, I'd like to give each of you a chance to share a final thought, a point you want to emphasize, that anything you want to say. Monica, do you want to start?
Sure. So again, thank you for allowing me to be part of this panel. So at Cincinnati Children's, our vision is to be the leader in improving child health, and that means all children. So regardless of, age, gender, sex, race, ethnicity, and we really want to hold true to that. We're excited about the next steps of our journey, which is building on the progress that we've been able to make. We're really proud that we're continuing to close the equity gap with infant mortality, asthma, and we want to continue that. We're also excited about a few other things. I talked about our mental health commitment in College Hill. We also just recently opened up our critical care building, which will serve our most critical patients at Cincinnati Children's Hospital. And we'll also be opening our Michael A. Fisher Child Health Equity Center, which will allow us to continue this work even more. And then finally, we have the ambitious goal. We have very ambitious goals, but we know that with our community partners and with our dedicated and diverse employees, we will be able to, and this is our tagline, change the outcome together. So, thank you.
Thank you. Michelle?
I think we touched on this during the panel session today, but for me, a big part of this work and partnering with communities is to support families and parents, caregivers, this intergenerational approach to improve outcomes for children. And one quote from a parent that we worked with that just stuck with me and I think really emphasizes this is, it's like when you're on a plane and they give you the safety briefing and they say, if there's an emergency, the mask will fall from the ceiling and you have to put on yours before you can put on your child's. And I think that's so true. And we're really well positioned to help families and support them to improve the outcomes for children.
Thank you. Greta and Cynthia.
Sure. Yeah, I think one thing that you've heard all of us say over and over again is we've talked about our partners. We cannot do this alone as single institutions. Sometimes I think academic medicine, we think we can do it alone, but we can't. We need partners all around us and the right partners, to Dr. Cross's point. We need partners who can help us bridge the historical mistrust that many communities, specifically in St. Louis, the African-American community, have felt with organized medicine. And without that, we would absolutely be unsuccessful and we just waste a lot of time and money. So the mission of St. Louis Children's Hospital is to do what's right for kids. And we know that doing what's right for kids includes partnering with our whole community in order to achieve that. So I'd like to thank all of our partners who've been on this journey with us.
Cynthia, final thought?
Yeah, this has been great, guys. I think diversity, equity, and inclusion, welcome all that come. Take the heart of a servant when you meet someone and really try to listen. The National Civil Rights Museum is here in Memphis, and we started our journey with them. Our CEO and our VPs got together and went there, and now we've had training for senior leadership. Because really folks won't tell us what they really need if they don't trust us. And Greta, you're right. We have to rebuild the trust in our marginalized communities. And I think we can do that. We also need diversity at the tables when decisions are being made, because sometimes people just don't understand what they're seeing. We had a question about why there were so many folks waiting in cars on our parking lot. And I said, geez, I know the answer to that. They dropped somebody at the ED, and rather than driving back home, they're just going to wait and play on their cell phone until they call for a ride. So just being there and not assuming that we know everything, right? Because we don't, and we don't have to. There are plenty of people around who can give us the information that we need if we ask. Thank you for having me. And I really appreciate what everybody had to say. It was great. I'm going to keep your contact info.
Well, the community health model is so striking for being united around a singular focus that you all share, is securing excellent health care for all kids and all adults through innovation, collaboration rather than competition, and it requires respectful communication and outreach to the community. And I have to say, in a time of polarization across the nation, it's an encouraging model for the whole country to embrace. Thank you all, Greta Todd, Dr. Cynthia Cross, Michelle Lopez, and Monica Mitchell, for enriching us with your insights and your perspectives. Thank you.
Thank you.
Thank you.